Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the fifth episode of brand new series, Optometry series. In this season, we are dealing with optometric and ophthalmological instruments. So, in this session, we especially going to concentrate on keratometer. I'm very happy to welcome my team members, Ms. Anshika ma'am and Ms. Nancy. Thank you so much for joining. I'm very happy to welcome the moderator for the day, Revathy ma'am. Thank you so much, Revathy ma'am, for joining us as the moderator for the day. We'd like to know more about you. To share more details about Revathy ma'am, I would like to call the MC for the day, Shivani. Please take over.
Good evening, one and all. I'm Shivani, studying third year, Bachelor's of Optometry at Dr. Agarwal's Institute of Optometry. I'm very happy to introduce the moderator of today, Ms. Revathy ma'am. Revathy ma'am is currently working as a senior optometrist at Shankara Netralaya, Chennai. Ma'am completed her optometry education at Shankara Netralaya. Revathy ma'am has been an optometry educator for more than 13 years. Ma'am's area of specialization is vision therapy and binocular vision. Ma'am is experienced in teaching contact lens practice through IACL modules and is well versed in handling a wide range of optometry subjects for both postgraduate and undergraduate students. We are truly delighted to welcome you, ma'am, as a today moderator. Thank you so much for joining us.
Thank you for the warm welcome, Shivani.
So the presenter for today is Ms. Nandhitha, studying second year Masters of Optometry at Dr. Agarwal's Institute of Optometry. Nandhitha, please start your presentation.
Thank you, Shivani. My screen visible now? Good evening, everyone. Myself, Nandhitha, pursuing Master of Optometry in Dr. Agarwal's Institute of Optometry. Today, we are going to see about keratometer. Keratometry is also known as ophthalmometer. It measures the curvature of anterior surface of cornea. Since the eye has a total refractive power of an eye about 60 diopters, where the cornea contributes approximately 43 diopter of the eye total refractive power. Keratometry measures the curvature of central 2 to 4 mm of the cornea. It measures the radius of curvature and convert into diopter using a standardized corneal refractive index, which is 1.3375. It is widely used in contact lens fitting, cataract surgery planning, intraocular lens power calculation, diagnosis of corneal astigmatism, monitoring corneal diseases such as keratoconus, and pre and post-operative refractive surgery assessment. Importance of keratometer provides objective measurement of corneal curvature. It measures the curvature of central cornea in the principal meridian and helps to identify whether the cornea is steep or flat. Helps ensure accurate refractive correction by assessing the corneal astigmatism. Assist in selecting the appropriate contact lens base curve. Important in contact lens practice. This allows the lens to fit properly on the cornea with centration and movement, improves comfort and visual performance, supports surgical planning and post-operative evaluation. Because corneal power is one of the important measurement in calculating the intraocular lens. Anatomy of cornea relevant to keratometry. As we all know, cornea is a transparent and avascular tissue located at front of the eye, serves as an eye primary refractive surface and contributes approximately two-thirds of a total refractive power. There are 5 layers of cornea, which the first layer is epithelium, second one is Bowman's layer, and third one is stroma, which consists of 90% of the cornea, and a fourth layer is Descemet membrane, fifth layer is endothelium. Important facts. Normal corneal diameter ranges from 11 to 12 mm. Central corneal thickness 520 to 550 mm. Average anterior corneal radius is 7.8 mm. Average corneal power is 43 diopter. Why the cornea is measured? Changes in corneal curvature can result from these conditions. Astigmatism, where the multiple focal points reaches the retina and irregular corneal curvature cause different refractive power. Keratoconus, It is a bilateral progressive condition where ectasia is happening. Corneal trauma, refractive surgery, contact lens fear, where in this condition changes in corneal curvature is happening. Since these conditions affect the eye focusing ability and measuring curvature is essential for diagnosis and treatment planning. There are four types of keratometer. First one is Joule-Chiarz keratometer. It is a two-position instrument which uses a doubling system, measures the principal meridian of the cornea, assesses the corneal astigmatism. It has a variable object size and it is a manual operation. Bosch and Loeb keratometers. It is a one-position instrument. It measures only the central 2 to 3 mm of the cornea. It is a fixed object size and variable image size. Automated keratometer. It is a computer controlled and it gives a faster measurement. It is a digital display and gives a high repeatability. Handheld keratometer. It is a portable and useful in children and bedridden patients. These are the four types of keratometer. The first image is a Joule-Chiarz, which is a two-position instrument and variable object size. And second one is most commonly used keratometer is a Bosch and Loeb keratometer. It is a one-position instrument which gives a fixed object size and variable image size. It is a third image is a automated keratometer, and fourth image is handheld keratometer, portable device. These are the components of keratometer. Tester's eye, where the examiner is testing the patient's eye. Eyepiece, measurement drum, locking knob, focusing knob, bulb, doubling prism, axis drum, objective, mirror, chin rest, and headrest are presented. There are three components of keratometer. First one is optical component. It consists of telescope, eyepiece, objective lens, doubling prism, and aperture. Mechanical component. It consists of joystick, measuring drum, chin rest, forehead, and base. Illumination system. It consists of Myers target and internal light source. Functions of each component. Eyepiece. It focuses the examiner vision. Objective lens. It forms the image. Doubling prism. It eliminates the error due to small eye movements. Measuring drum. It measures the corneal curvature. Joystick. It aligns the instrument. Principle of keratometer. The keratometer works on a doubling principle. It acts as a convex mirror principle. It measures the reflected image of illuminated Myers. The below image shows a black circle in the center represents the visual axis of a Placido disc. Concentric rings are the Myers, where the steeper cornea has a less space and it gives a smaller reflected image and it provides and indicates a higher corneal power, where the flatter cornea, which is a more space and it provides a larger reflected image, which indicates a lower corneal power. Optical components. Cornea behaves like a convex mirror. Myers image are reflected from the tear film covering the cornea. Doubling prisms are used to prevent the error caused by a small eye movements. Measurements are taken in the two principal meridian of horizontal and vertical to determine the astigmatism. So this image shows the Bosch and Loeb style of keratometer. The light from the keratometer is reflected by the cornea to form a Myers image. The keratometer measures the size of the image determined the corneal curvature. So the steeper cornea has more curve and it gives a smaller reflected image, where in the flat cornea it is less curved and it gives a larger reflected image. Precautions during keratometer. Avoid blinking, maintain steady fixation, ensure proper head position. Procedures. Explain the test to the patient, clean the head and forehead rest, calibrate the instrument, adjust the eyepiece before starting the procedure. Position the patient correctly. Ask the patient to fix on the target. Focus the Myers. Align the horizontal and vertical meridian. Record K1 and K2 axis. Lower corneal diopter is considered to be the flat K and higher corneal diopter is considered to be the steep K. Repeat for the fellow eyes. Myers system. Mires are illuminated targets projected onto the cornea. Purpose: it produces two reflected image and it measures the central 2 to 3 mm of the corneal curvature and it determines the principal meridian and it calculates the astigmatism. Types of Mires: circular, cross, plus and minus signs. So these two images shows the Mires image. The first Mires is not coinciding with the minus and plus signs. It is not focused correctly. So this suggests incorrect positioning or astigmatism. The second image shows the plus and minus signs are coinciding with each other. So this indicates the proper alignment. Keratometry reading. Measurements obtained. Flat K, TK, radius of curvature, corneal power, and axis of astigmatism. Example, K1 is 42.25 diopter at 180 axis, K2 is 44 diopter at 90 axis. The astigmatism present is 1.75 diopter. As I already told, lowest corneal diopter is the flattest K and higher corneal diopter is the steepest K. And whereas it is vice versa in radius of curvature. Larger radius is the flattest cornea and the smaller radius is the steepest cornea. Normal values are radius 7.5 to 8.5 8 mm. Corneal power 42 to 44 mm. Clinical applications. Uses of keratometry. It is used in contact lens fitting, diagnosis of regular astigmatism, cataract surgery planning, IOL power calculation, refractive surgery evaluation, keratoconus screening, monitoring corneal diseases, and post-operative follow-up. Assumption of keratometer. Keratometry is based on several assumptions to simplify the measurement of corneal curvature. Assumptions. The anterior corneal surface is spherical in the central zone. The posterior corneal curvature is constant and not measured directly. The refractive index of the cornea is assumed to be 1.3375. Only the central 2 to 4 mm of the cornea is measured. The tear film is smooth and it provides a regular reflecting surface. Clinical importance. So these assumptions allow quick estimation of corneal power. It may reduce accuracy in irregular corneas such as keratoconus or after refractive surgeries. Role in contact lens practice. Base curve, lens diameter, initial lens selection, lens centration, lens movement, and tear exchange. Clinical benefits. This provides a better comfort and improved vision and it reduces the complication due to improper fitting of a contact lens and it provides a healthy cornea. Cataract surgery. Role in IOL calculation. Keratometry provides a corneal power which is combined with an axial lens and to calculate the intraocular lens power. Importance. Accurate post-operative vision and it reduces the refractive error after cataract surgery. Better patient satisfaction. Advantages of keratometer. It is a non-invasive method, quick, accurate, simple to perform, cost-effective, reliable, portable, useful in routine practices, and it's highly reproducible. Limitations of keratometer. It measures only 2 to 3 mm of the cornea, assumes spherical cornea, and it cannot access the posterior cornea, less accurate in irregular corneas, affected by tear film quality, limited in advanced keratoconus. Sources of errors. Patient error, frequent blinking, poor fixation, dry eye, head movement. Instrument factors, poor calibration, dirty optics, improper illumination. Examiner factors, incorrect focusing, misalignment, recording errors. To prevent these errors, calibrate it regularly, maintain tear film, repeat measurement, and ensure proper alignment. Advances. Automated keratometers, optical biometers, placido disc topography, sham plug imaging, corneal tomography, AI assistant corneal analysis, integrated electronic health records. Advantages. Faster, it is more precise, better repeatability, comprehensive corneal assessment. Summary. It provides an objective measurement of the anterior corneal curvature. and it plays a crucial role in contact lens fitting, cataract surgery, refractive surgery, and diagnosis of corneal diseases. Despite advances in corneal imaging, the keratometer remains fundamental role because of its simplicity, reliability, and clinical value. Accurate keratometry is the foundation of successful refractive assessment and its management. These are my references. Thank you.
Thank you so much for the detailed presentation, Nandhitha. Um, um, Revathy ma'am, if you have any points to add on, can you please add at this point?
Hello, yes. So I would like to add a few points, especially on calibration, since it was not discussed much. How do you calibrate the keratometer? How frequently you have to calibrate the keratometer? Is my voice audible?
Yes, ma'am, your voice is audible, but the video is unstable.
Okay. But that is not a problem, no? Is it okay?
Should be fine, ma'am. You can go on.
If audio has a lag, just let me know.
Sure, sure. For now, it's okay.
Okay. So regarding calibration, how do you calibrate a keratometer? The manufacturer will be providing you a steel rod which can be fixed to the headrest. You have a headrest. I would like to show the headrest.
The audio is
One
not
minute,
clear,
one
ma'am.
minute. Can you see the video now?
Yes, ma'am.
Okay. So you can see here, this is the, I mean, is attached to the headrest. Chin rest is here. This is where the patient's forehead must touch, right? So you'll be having a rod which can be attached to this part, okay? And the rod will have a spherical ball.
Revathy ma'am, sorry ma'am.
Mm.
Your video is actually not moving, ma'am. We are not able to see video actually. I think
Okay.
Because of the bandwidth.
Sorry, because of the?
because of the
Bandwidth.
I think this
Video is
place.
actually not working
Uh-huh.
properly, ma'am.
Okay. Okay, the place has very poor signal. No Wi-Fi also. Okay, I'll confine to the audio. So how to calibrate is, one thing is by using a metal rod which can attach itself to a ball by using magnet. So they give like three types of balls usually in different curvatures. Let's say 42, 44, and 46. Okay, what happens is you have to use this metal ball and perform a keratometry on that ball. So it has to correlate with the value given by the manufacturer. Let's say you take a ball of 44 diopter curvature, it should correlate. Otherwise, you'll have to recalibrate the instrument. So why calibration is important is for precision of your readings. As she said, in the uses of keratometry, we know that it is used for different purposes. One is like basic OPD refraction, ranging from basic OPD refraction to calculation of IOL in cataract surgeries. So right, there is a formula which accommodates the keratometry readings for calculation of IOL power. Are there students in this presentation or?
Yes, ma'am, we'll have students also attending it online. A few students from other
Okay.
places are also visiting it.
Okay. Can they answer if I ask any questions? No. Or is it one-way communication sort of?
Nandhitha can answer.
Nandhitha can answer. The presenter can answer. The rest of them are not given access to
Okay.
that.
Fine, fine. Okay. So can she answer like how much keratometry reading is going to contribute in the calculation of IOL formula? No, not the exact formula, just like what is the role of keratometry in calculation of IOLs?
Nandhitha, please unmute yourself.
Yes,
Answer.
ma'am. Role in, ma'am, your question once again, ma'am.
What is the role of keratometry reading in calculation of IOL power?
To identify a corneal refractive errors,
Nandhitha, please switch on your video and then answer.
to identify a corneal refractive errors, ma'am.
Okay, that's for refraction. What is the role in IOL power calculation? Chari, okay, just go back and check that. Okay, there are different formulas for calculating IOL powers. For example, let's say SRK and SRKT is the most common or the most common formulas that are used. So the formula goes like this: you'll have a lens constant, and you'll have a K reading, and you'll have your AXL measurement. The formula combines everything, like the difference of lens constant and zero point 0.9 into keratometry reading minus 2.5 into your axial length. So the minimum contribution is going to be like 0.9 times the keratometry. Let's say there is a keratometry value. If you measured it wrongly, if the precision has gone wrong, so whatever error we are going to make is going to be reflected in the final IOL power. Let's say there is an error of 0.5. Okay, so the error also will be like 0.5 diopter. If you overestimate it by 0.5, there will be a myopic overestimation, and if you underestimate it, there will be a hyperopic estimation. Also, the same formula using the keratometry value is going to be planned for effective IOL positioning inside the eye. So the positioning also is going to become wrong if we have a error in the keratometry reading. So what we generally do is we check for inter-observer variability. She also mentioned it, Nandhitha also mentioned in the presentation that it has to be rechecked. I mean, your keratometry values have to be rechecked. So why it has to be rechecked is for checking the intra-observer variability. For example, if I'm going to perform some measurement, let's say 2 times or 3 times, the value should be reproducible. The repeatability should be okay. Then only your values are going to be precise. Inter-observer variability is going to be something between you and another examiner who performs the reading on the same cornea or same patient. So if it is going to be a significant, if there is going to be a significant variability in the values, then also your precision is under query. Okay. So this is how we keep a tab on precision of the keratometry readings. So first step to ensure the precision is by proper calibration. So one is the rod, which I said will be coming along with the equipment. Usually in a OPD practice, sometimes it may be with one person or the bioengineering, you may not have an access to it. So how else do you make sure the proper calibration is done on a regular basis? Let's say once in 10 days, once in a month, if you have to perform the calibration. If you look at a keratometer that is available in your practice, you can see that it has a occluder. Yes, Nandhitha, have you seen it?
Yes, ma'am.
Okay. The occluder itself has a small concave surface, like say it is of 3 to 4 mm maximum, so which is stuck to the uh, observer side, examiner side of the keratometer. Like it will have two sides, right? The occluder is going to face the patient and also you on the other side of the telescope. So now this occluder is going to have a small concave surface on one side of it. This this concave surface will have a measurement like let's say base curve of 7.5 base curve, which is the standard one used in Bosch and Lomb keratometers. So now you can calibrate using this concave surface to check if the keratometer is working fine, if it is precise, if it is precisely calibrated to that particular reading. 7.5 translates to 44 diopter of corneal power. Okay, 7.5 radius of curvature equals to 45 diopter. So if you take a measurement that surface, the value should be correlating to that specific value mentioned in the mentioned about the surface. Okay, this is the way you should be calibrating. And one more thing to avoid other errors, the errors can be like patient specific, instrument specific, examiner specific, and all that. So to avoid errors from the examiner side, you have to focus the Myers for each and every reading. That is like crucial, because generally in a hospital practice, let's say there is a floor with 5 to 6 OPD rooms for optometrists, which implies that the instrument is going to be used by more than one person, right? More than one optom will be using it. So each time you make a patient sit on that instrument, you have to focus it, adjust the eyepiece according to your refractive error. Like how when you see the Myers clearly, then only you can start taking the measurements. That is one important thing. And one more thing is she also included this in her presentation. I just want to mention the importance of it. Proper positioning of patient. Okay. As you said in the limitations, the meter to measure the central 3 mm of the cornea. So if the patient is not fixating, I mean, how do you ask the patient to fixate, Nandhitha, when you take the keratometry reading?
We ask a patient to fixate at the Myers, no?
Myers, do they see a Meyer?
No, the mirror
You'll be the
inside.
one.
The
Mirror.
mirror,
They'll
no?
be seeing their, yes, they'll be seeing their own eye in the mirror, right? Once they see it, they'll have to fixate at the image of their eye, and you'll be taking the measurement. So that is the correct position. Also, to ensure the level of positioning, there will be a pin in the patient side on the headrest. So that pin has to correlate with the canthus on the side. I mean, if you are taking the measurement of the right eye, it has to correlate with the right canthus. If you are taking on the left side, it has to correlate with the left canthus. If the patient has a strabismus, let's say, will it affect the readings that you take?
Yes, no.
How?
If the patient fixated, we can
Hmm.
start doing the procedures. If the
Yes.
patient has any tropia, means it's difficult to do further procedures.
Okay, let's say the patient has good vision. He can see the cornea, but he or she has a strabismus. Let's say um, exotropia is there. Okay, how do you make sure proper fixation?
To occlude another eye.
To occlude the other eye, which has to be done for all the patients. Okay, even smaller amounts of tropia, which we don't, I mean, let's say you performed the refraction and keratometry even before you assessed the extraocular motility status and the cover test and all. So you'll have to do it even if there is 8 prism diopter of squint, which is not very visible before you perform the cover test. It is going to affect your readings because you're not measuring the central 3 mm. Even if the eye is slightly deviated from the central line, it is going to give a very different measurement. Okay. And one more question is, what is the instrument calibrated for? What refractive index is it calibrated for?
Corneal refractive.
What is the refractive index that BNL keratometer is calibrated for?
1.3375.
Why is it calibrated? What is the cornea's refractive index?
1.3375.
Is it? You can
1.33.
answer.
1.3361.
1.376. Okay, that's what cornea's refractive index is. But the keratometer is calibrated for a refractive index of 1.3376. Why is it so? See, what is the principle behind measuring your keratometry measure? You have a Purkinje image 1, yes, to see the corneal reflection, and that corneal reflection is used for this keratometry assessment. So you're actually seeing the measurement from the front surface of the cornea, right? So actually, what you're measuring is total astigmatism. That's what you call it, right? We don't mention it as corneal front surface astigmatism anywhere in the file. So it's going to be total astigmatism. How does it account for total astigmatism when you are just using Purkinje image 1 is, we are taking this refractive index with the account for posterior surface of the cornea also, which is in contact with the aqueous humor. Yes, aqueous humor refractive index is Seri, okay. And also the concavity of the posterior surface. Corneal front surface is convex, corneal back surface is concave, right? So the refractive index that it is calibrated is adjusted for the refractive index of the posterior surface and also for the concavity of the posterior surface. That's why we have a different refractive index for which it is calibrated. Okay? Yes?
Okay. Yes, ma'am.
How do you use it in the refraction is, one is whenever you suspect astigmatism, presence of astigmatism, before refraction itself. Nowadays, I see this practice. Whenever you get a patient, you just take them to the autorefractometer. There is nothing wrong in it, but you just get an idea of what the total refraction is even before you start the workup. So along with it, if the autorefractometer is going to give you a keratometry reading also, you are going to get an idea of what the astigmatism also is, right? So this is performing a keratometry in each and every patient, even before you start a workup. One more thing is, we didn't have this practice before. So you don't have a auto refractometer in every place. So what we used to do is, whenever there is a 1 minute. So whenever there is a astigmatism which is greater than 1.5 diopter cylinder, okay, in your refraction, if you get a refraction of 1.5 diopter astigmatism, it is mandatory to perform keratometry. Why? Because you need to know, first thing is, how much of it is corneal, how much of this astigmatism is because of the corneal toricity. And if your astigmatism that you get in the refraction, the axis of that and your corneal astigmatism, if they correlate, okay, that is one thing. And how much of it is internal astigmatism. As you said in your presentation, if this patient is going to go for a contact lens fitting, as you said, the first point is to select a base curve for this patient using the keratometry value. We'll come back to this again. One more thing is, if the astigmatism is going to be internal astigmatism, or if it is because of the back toricity of the cornea, then you'll have to choose a lens design, contact lens design, according to the toricity that the patient has. Okay. So if you are going to fit the front surface astigmatism patient with the RGP lens, let's say it's a spherical RGP lens, most of the toricity of the cornea will be compensated by the RGP spherical lens itself. Whereas if it is back toric, if it is due to the back toricity of the cornea, then RGP spherical will not do justice, will not correct the astigmatism fully. So you'll have to go for a RGP toric design or some other design which compensates for the back toricity and the internal astigmatism also. Okay.
Okay, ma'am.
What else is indication for performing a keratometry is if you see a scissoring reflex in the retinoscopy. Okay. What does it indicate? What will you
To
suspect?
suspect keratoconus, ma'am.
Very good. So we may suspect keratoconus. In those cases, we have to perform a keratometry immediately. Also, to get an idea of how much astigmatism, how much toricity that cornea might have. Okay. Sometimes it is not perfectly measurable with your retinoscopy itself. The toricity might be so high that it is, very difficult to measure it only with the help of retinoscopy. So we take the measurements from keratometry also and correct the patient accordingly. And one more thing is, if you suspect a keratoconus, the amplitude of astigmatism that you get in keratometry and the value itself, let's say if it is 45, what is the normal corneal astigmatism? You mentioned it in your presentation. It's 43 to 45,
40,
right?
42 to
So,
44.
exactly. So if the patient's keratometer value shows you 45, we assume it is normal. But even though if this value is normal, we cannot rule out the presence of keratoconus. It might be a early keratoconus also. That is one point. Also, keratometry gives you an idea of how steep the cornea is. If it is 48, it also indirectly implies the severity of the keratoconus that is present in this patient. Okay. And what is the range of keratometry? Like the range of measurements we have in normal manual keratometer.
60 diopters.
Okay. It's 36 to 52 diopter. Okay. So what if the patient has a abnormally flat cornea? The cornea's measurement is flatter than 36 diopter or abnormally steeper than 52 diopter. We perform something called extended keratometry, because all the places may not have a corneal topography machine or all the advancements that you suggested, right? Or automated keratometer of an extensive range. So extended keratometry helps you to measure flatter corneas. From 36, you can extend it up to 30 diopter. From 52, you can extend it up to 60 diopter. How do you extend it? Is using additional lenses that are placed over the eyepiece. Okay. If you want to flatten it from 36, we use a -1 diopter lens. Okay. Whatever values you measure in the keratometer with the -1 diopter over the eyepiece, let's say if I'm measuring 36, it implies that the value is 30. Okay. -6. Okay. If you measure 37, it is -631 diopter. Okay. If you are measuring a steeper cornea, we use a +1.25 diopter lens over the eyepiece, which roughly translates to +8 diopter from the readings. Let's say you are measuring 51. Okay. So the actual value is going to be 51 +8. But again, put under quotes, this is not the exact value. You are going to use this for a baseline keratometric reading only. Okay. The actual correct value in the steeper or flatter corneas can be given by automated keratometry, which has that range, or you have to go for a corneal topography. These values cannot be taken very seriously for like surgeries and all that. So if post-refractive surgery patient comes to us and if if the cornea is abnormally flat, we cannot use this value for calculation of IOL and all. We have to resort to the other diagnostics. Okay. But just to know that the range can be extended from 36 to 52 to 30 to 60 with the help of extended keratometry. Okay.
Okay.
Okay. And one more thing where keratometry is useful is when there is a media opacity. Okay. We don't know the actual retinoscopy value, or we don't have other methods to find out. So we want to do a refraction in this patient using a trial and error method. Where do we start with? So what we do generally is to perform a keratometry if the cornea is at least smooth. despite the other media opacities and all, or other ocular problems the patient may have. So we perform a keratometry. With the help of the keratometry readings, we start our initial lenses in the trial frame. Let's say, as you said, the normal corneal keratometry value is 43 to 45 diopter. So if the value is 44 diopter, we assume the patient is emmetropic, right? Not, we didn't take the AXL value, but still this gives you a gross idea of the refractive status of the patient. Okay. So if it is 48 diopter, what we assume is it is 4 diopter in addition to the normal value. So you'll have to start with a -4 when you do a trial and error refraction. The cornea is steeper, so we assume the patient's refractive status is myopic. If the cornea is flatter, it may be assumed that the patient's refractive status is hyperopic. Generally, if you notice the trend of keratometry values in significant hyperopic or myopic patients, it will adhere to this trend. So let's say I get a +5 diopter hyperopic patient. Mostly the corneal keratometry values will lie around 40 to 41 diopter. It will be flatter than the patient. Same can be observed in myopic patients. The cornea tends to be steeper than the normal values. Okay. Also, let's say I want to fit a corneal patient, a corneal patient with a contact lens. Let's say I want to fit a prosthetic contact lens, but the cornea is not very regular, so I cannot get a reading using keratometry with that eye. Yes. So what I have to do is I'll be performing keratometry in the normal eye. With that as a baseline, I can select my contact lens base curve to fit the eye with the irregular cornea. Based on the fit, we can alter the trial lens going forward. So these are some of the points I wanted to add. And one more important thing is about blinking. We mentioned that the patient should not blink excessively while taking a measurement because that is going to, disturb our reading, right? But actually, the patient has to blink frequently when you take a keratometry reading, because sometimes what they do is we ask them to fixate at their own eyes reflection. So they tend to do it for longer times. If we take more time to focus the images, align the drums, everything, sometimes the eye goes dry. You would have noticed in your, when you see the Myers also, the Meyer just breaks when you perform keratometry for significantly longer times. So you'll have to ask the patient to blink often to make sure a proper tear film is there above the cornea. That will only give you correct readings. Okay. Sometimes what happens in DBR and all digital biometry reading, when we perform keratometry, when the patient focuses on the image for a longer time, and elderly patients tend to have dry eye also. So the readings will not be accurate if the Myers are not clear, if the tear film breaks up. Okay. So even use of refreshed tears amidst the measurement is encouraged to ensure a proper tear film layer while taking the measurements. Okay. So if the patient is going to have a severe dry eye, know that your keratometry readings may get affected because of the tear film quality also. Okay, you'll have to make sure the patient has a good tear film when you perform the readings to ensure the you get precise readings. Let's say the patient is using contact lenses. Okay, the patient has used contact lenses today also. If you want to take a keratometry now, what should you do? What is
Ask the
the
patient,
precaution that you have? Hmm.
ask the patient to remove the contact lens, and then we
Yes.
start the procedure.
Excellent, very good. So if it is soft CL, you can just ask him to remove then and there, and you can go forward performing a measurement. If it is RGP, it is going to have some corneal changes post RGP wear. So we encourage the patients to discontinue lenses at least before 2 weeks if you are going to use that measurement for any IOL calculation or before refractive surgery calculations and all. Okay. Even soft CLs also, we encourage them to discontinue for a week. Okay.
Okay.
So if it is just for documentation purpose, you can go ahead with it. But even then, the precision will not be that accurate. So in corneal ectasic conditions, as I said, manual keratometry is not going to have much value. Mostly will be relying on corneal topography and all. Okay. Because all the assumptions that based on what the keratometry is built is cornea is spherical, the central 3 mm is measured, and all the assumptions that were made is not for ectasic corneas. It is for normal corneas only. Okay. Where else you'll be performing keratometry is pre and post refractive surgery patients, like added to the regular OPD patients where you see astigmatism. In all pre and post LASIK or any other refractive surgeries, we need to document K. Okay. And if there is a post-corneal transplant, or if you are monitoring keratoconus progression or PMD's progression, you need to document cornea's curvature in every visit to see how much it has changed since the last visit. And one more important question that I have got is, what do you vouch for? Like, what are the advantages of manual keratometry over the automated keratometry? I mean, we all know automated keratometry has an extensive range. It can be performed easily. One click, it gives you the measurements and all that. Are there any advantages beyond all this in manual keratometry? What is the advantage of retinoscope over your autorefractometer? Why do we still prefer retinoscope in refraction?
It gives accurate subjective reflection.
Objective refraction, you mean? Okay. Any other point is there? You get to see the reflex, right? Which you are not seeing in the autorefractometer. If there is a small corneal opacity or small lens opacity, you get to see it. If it is in the visual axis, you get to see it only in the retinoscopy. And the quality of the reflex, how is it? Is it scissoring? Everything can be told with a single I mean, if you focus the retinoscope on the patient's eye. Same thing with the manual keratometry also. The quality of Myers have something to tell us, like how good is the cornea, how smooth is the cornea, what is the tear film quality actually. Even before you make them sit in the slit lamp, you can tell if the patient is having a low TBUT. Tear breakup time is lesser means you can easily tell that. We actually perform something called non-invasive TBUT using keratometry. How is it performed?
To monitor the dry eyes, ma'am.
Right. It is to
Non-invasive method.
monitor dry eye. Why is it non-invasive? Why using keratometry is non-invasive?
No staining, ma'am.
No staining, no paracaine, nothing. So while performing keratometry, you can easily see how long the tear film can hold on to the cornea. So these are some of the points I wanted to add. That's it. Don't ignore dry eye is one key point whenever you do a keratometry. Proper calibration, periodical calibration is very important. Precision is important. Whenever you have a doubt, you can recheck your values with somebody who is also good in performing keratometry. A good training, keeping up with the training and all is important to ensure getting a precise keratometry value. Okay. So that's all. Thank you. Thank
Thank
you,
you.
Nandhitha. That was a good.
Thank you so much. Sir. Thank you so much for joining us as the moderator for the day. Anshi ma'am, would you like to add any more points for the session, ma'am?
Hi,
Because
Revathy.
Revathy ma'am has given a complete guide towards
I
calculating. I don't think you'll be having any points to add.
No, I would just like to thank Revathy. Thank you so much, Revathy, for giving, like how Gomati said, it's a comprehensive overview on optometry. So, sorry, keratometer. So we started with the optics and how different keratometers have what optics, or it is a convex mirror principle that students should remember. And you actually concluded it with how it is important, even calibration and focusing, how important it is, and then how do you move on with extending the keratometer ranges and how do you take care of it. So thank you so much, Revathy. I think it is a wonderful presentation. I hope many students do watch it and understand that how we, put in instruments, and now we are learning CVS and clinics like in one presentation fully. So it's really inspiring. Thank you, Revathy. Thank you so much.
Thank you, Anshika. Thank you, Gomati, for the opportunity, coordination, everything. Thank you, Nandhitha. Thank you all.
Thank you, ma'am.
Thank you so much. Another wonderful platform, ma'am. So the announcement for
Bye.
this is we are excited to announce about a new workshop that is coming up. So the announcement in detail will be made in the next episode of Optometry series. Until then, if you like this video, give a thumbs up and share with all your friends. We'll meet you in the next episode. Thank you, team. Thank you, Revathy ma'am.